This is your body saying, hey, I finally had to throw down this really big, scary word at you so that you would stop and listen, so that you would stop and look. And so now let's just work to see what is out of whack and what can we do to help you bring balance back. There is data showing that diabetics are much more likely to get cancer than non-diabetics, and that diabetics on insulin are more likely to get cancer than diabetics who are not on insulin. You feed the animals omega-6 fats like soybean oil or corn oil, and they grow cancer. And if you feed them, coconut oil and palm oil and those saturated fats, they don't.
So as we go through our conversation, we're going to really take some time and get into prevention and treatment of cancer. But I think as a baseline to get us all on the same page, a good place to kick off is to talk about the physiology of a normal cell turning into a cancer cell. So let's start there and we'll build from there.
So in cells, we can burn a lot of different fuels for fuel, right? We can use our sugars when sugar is around, or glucose. We can use fatty acids. So cells are really robust in what they can do, but where does that energy production happen? It's in the mitochondria of cells. And mitochondria actually kind of dictate what's going on in that cell. When they start to get stressed out or damaged for some reason, they actually start to send out some stress signals, even to the nucleus, which can tell the nucleus, you're a different cell now. You need to do things differently. But as mitochondria become more and more damaged, they tend to now, instead of using mainly fatty acids for fuel, they convert more to using an anaerobic pathway. So even though oxygen might be around, they start to burn glucose preferentially, and they need more and more of it to sustain themselves. So it kind of, the cell transitions into the every man for themselves type of cell. When cells are healthy, we're all living in a community. We're doing our jobs. The liver cells are doing what liver cells need to do, and they're taking up only as much space as they need. But as cells become damaged and they start to revert back to kind of that single-celled organism mentality of, I just am here to survive until tomorrow. And how do I do that? And the cells start, because they need more and more glucose, and again, in this kind of anaerobic metabolism, even though oxygen is present, and this has been named or known as the Warburg effect, which many of your listeners, I'm assuming, have heard about. But this Warburg effect, these cells now are behaving differently, and they start to upregulate their insulin receptors. So insulin receptors are on the surface of all of our cells. So when glucose is present, insulin is released from our pancreas, binds to cells, tells the cells, hey, there's glucose around. Okay, let's pull some glucose in. But these cancer cells are these damaged cells. So it happens even before cancer becomes present. We have this process. So we're in cancers, when we have very low grade or even kind of benign tumors, we have some of that damage happening. And as cells become more and more aggressive or highly proliferative or growing fast, they need more and more of this glucose to do that. And so they upregulate insulin receptors. Again, insulin's the key to the door, pulling that glucose in and telling the cell, hey, there's a lot of glucose out here. So the cancer cells then use this glucose, these carbon molecules in the glucose structure, to build new cells. And these insulin receptors, or these insulin signals, are further growth factors for the cancer cell. So the cancer cell's being told, hey, there's lots of glucose around, bring it on in and let's use it. Whereas our normal cells, they can use glucose if we need to. If we're in an anaerobic state, we're doing a 100-yard dash and we're sprinting, we're doing muscle, weight training, and that muscle fatigue, we feel that lactic acid burn. We are in an anaerobic state and we're using glucose. But at some point, our brain says, hey, take a break, breathe, let's get oxygen back to the tissues, let's heal, let's get back into our steady state of mostly using our mitochondria to create nice fuel using different pathways. So again, as our cells slowly become more damaged, it's usually a function of mitochondrial damage that happens over time.
All right, that makes a lot of sense. And I think it gives us a good platform to jump off of and take various tangents. And where I want to go before, again, we get to the prevention and treatment is this piece of the mitochondria becoming damaged. So we know this is what initiates a regular cell to become cancerous. Let's talk about some of the top things that are causing that mitochondrial damage.
So we know that toxins in our environment can cause damage. The drugs we're given, even, good pharmaceutical drugs for some chronic disease we have, might slowly be actually damaging those mitochondria. Food, we have the fake food environment. We have, processed seed oils and highly refined grains and sugars, high fructose corn syrup. We have lots of toxins in our food environment. And if we are in some degree of, an already, I should say they compound on each other. So somebody who's already starting to have some sluggish metabolism, some broken down mitochondria, if we're constantly in a high carbohydrate, high sugar, high inflammatory fat environment, we're actually compounding the problem. Bam, bam, bam. But we can get it, from anything that creates imbalance in our bodies. If we start to become completely sleep deprived, and sometimes that's because that's now driving more insulin resistance. It's driving, us to eat a different way because we're just trying to stay awake, or we're pounding, Red Bulls or something, so we're constantly in, and I'll go back even most simply. We all know that smoking is a mitochondrial toxin. I mean, we've talked about smoking causing cancer for decades. But all of those lifestyle habits that we know maybe aren't quite so good for us really do take a toll on our cellular health, which can then predispose us to those next set of chronic diseases. And I don't treat cancer like a special disease, even though I'm a cancer doctor. It's no different, in my opinion, than somebody getting diabetes or, cardiac disease or other things. These are all mitochondrial dysfunction diseases. And I kind of feel like, maybe our genetics predispose us to which of these diseases we might get. But if we really pull ourselves back to that root cause, really they're all coming from the same things.
Which is actually great news for us, because all we need to do, quote unquote, is to support the mitochondria. And it's going to take care of all these various chronic health issues.
Exactly.
So the way I understand it, just highlighting what you just said there, cancer can almost be looked at like a symptom of the mitochondrial dysfunction. And maybe the person that gets cancer versus diabetes or a different chronic disease, that's where the genetics may come in.
Yeah, 100%. And again, I don't want to cloud this with, cancer is a genetic disease. It's certainly, we know that if we truly look at it, even from a conventional standpoint, how many cancers are genetic, it still is a very small percentage. But if we go upstream, why is it that only some BRCA1 or 2 patients get breast cancer? Why don't all of them get breast cancer? Well, because some are maybe using better diet and lifestyle tools and optimizing their mitochondrial health, and they never get the disease. But we don't go that far in conventional medicine to really look at, okay, why did these people get it and these people don't? We just say, it's in your genetics, therefore you're more likely to get it.
The latest YouTube stats are showing that only 12% of the people that are watching these videos are subscribed to the channel. If you haven't subscribed yet, take a second and do so below. Help the community continue to grow and help this show continue to bring on the biggest guests. Thank you ahead of time. Continue to enjoy this episode with Dr. K. All right, we've done a good job here of summarizing all the overview of what we're going to get into. We've talked about some of the negative influences that can damage the mitochondria and lead to cancer. Let's take it from the other way around now and talk about some of the positive influences ways we can support the mitochondria and hopefully prevent cancer or fight cancer if somebody's in the boat where they already have cancer. And I know for you, the biggest lever in this realm is you've touched on diet, and more specifically, the ketogenic diet. So let's talk about why this is so pro for the mitochondria.
So when we eat a ketogenic diet, we are significantly ratcheting down our glucose in the system. So we're eating very little carbohydrate, which is broken down into glucose, which can then stimulate insulin. So now not only are we bringing down glucose, we are bringing down insulin. So what has been shown in numerous trials is women or men, depending on the study looked at, but those who have higher insulin levels have higher risks of recurrence, have higher risks of metastatic disease, have higher disease stages at the time of diagnosis. So what we know is that if we have lower levels, those things are not as bad. There's actually data, yes, even in humans, we know we don't seem to hear about it very much, but even some small studies looking at humans putting cancer patients on ketogenic diets, or maybe not what is typically known as a ketogenic diet, but other fasting mimicking diets, because there is some distinction out there, although really the bottom line is getting a person into a metabolic state that is creating ketones. So any fasting mimicking diet, in my opinion, is a ketogenic diet. But that being said, in these studies, it seems that the therapies are significantly augmented. Even stage 4 patients who maybe aren't expecting any big drama, they're just trying to, so there's stage 4 colon cancer patients that were put on ketogenic diets or standard of care. And those patients on the ketogenic diet in stage 4 that really just were getting chemotherapy, it was kind of palliative chemotherapy, so they weren't expecting any cures. And I'm not saying that any patients were cured, but the response rates were dramatically better in the ketogenic diet. In fact, 50% of those patients had complete responses to the diet with their standard of care palliative chemotherapy versus standard diet and chemotherapy. And in the standard diet group, 0 patients had complete responses. Now, some of them had partial responses, which is great, but the power of adding that. So why is that? When we feed our normal cells ketogenic diets, they operate just fine. They can operate any which way we want to do it. And we're keeping them healthier by not bathing them in high glucose states. But very interestingly, when we follow a formulated ketogenic diet, so we're not saying bad fats like those seed oils and salad dressings and mayonnaises typically at most grocery stores, but really optimizing the natural fats that come in our animals, and maybe some olive oil or coconut oil or other, I always say fruit oils as opposed to vegetable, nut, and seed oils. But when we optimize those foods, we're not bathing our healthy mitochondria in toxins. We're removing a lot of those foods that create the problem to begin with. And because those cancer cells have damaged mitochondria and they need more glucose, they need that insulin signaling for growth, we're taking that away, or we're keeping it extremely limited. So now we're taking away, and we will always have glucose in our system and we will always have insulin. So when we say we're starving cancer, we can't shut it off completely. We need it to live. But can we make those cells so fragile now that our therapies work so much better, because those cells are so ready now to be killed by whatever therapies we want to use, whether that's conventional therapies or other oxidative stressors to those cells. We can really enhance that effect when we put the stress on those cancer cells, take away their preferred fuel, or at least ratchet it so far down that, and when we're burning fatty acids, we're shutting that, even though there is some glucose and insulin in the system, we're actually shutting it down further.
Is there any research comparing fasting in that case with traditional chemotherapy versus a ketogenic diet? which is a fasting mimicking diet. But I'm just curious on the nuance.
I wish. No. So really all studies at this point, at least the ones that I can find, are either there's a chemotherapy trial with water fasting. There's chemotherapy trials with severe calorie restriction fasting. And because those are not sustainable, they were only doing them around the chemotherapy. So a day or 2 or 3 or 4 around that dose of chemotherapy. The beauty of a ketogenic diet, right, is that we get into a fasted mimicking state. Sometimes we can make it. We can do a little calorie restriction or fasting around our chemotherapy, but we can then continue it day in and day out for our entire course of therapy. Maybe we're going to stay in a ketogenic state for 6 months or a year. Some of us, many, many, many years. I wish that we were looking more closely, but right now, I just wish that the conventional world was even looking at this Warburg idea more robustly. I know people in the research world, and I will bring it up. Hey, why don't we do a study? Oh, there's just not enough data on that yet. What? I think there's so much data and really so much pathophysiology that we can say, but this should really benefit a patient. Like why? And I work with patients every day, and most of the time, the next day they're like, oh my gosh, I feel so much better. It's like within days, they're like a light switch has flipped and I finally feel great, even though I know I still have cancer. Just my energy level is better. My joints are better. Like they're already feeling better. And I lost that extra 30 pounds of fat mass that I had right in my belly, so that you can see people get healthier. So I don't know why there's such the resistance in most conventional medical offices when we're talking about diet and cancer. Most of the time it's don't lose weight while you're going through therapy. And I know why they say that, but don't lose weight while you're going through therapy. Don't do that crazy ketogenic diet. You're going to, have a heart attack or something. Yikes. So anyway, it's just a lot of misinformation. And I think that the step one is really, can we get them to start incorporating these techniques into cancer therapies? And then we can get into nuances of looking at water fasting versus calorie restriction versus ketogenic diets. And my guess is that a ketogenic diet will win only because you can do it for the entire course.
All right. So to summarize here, when we use one of these different modalities that's going to improve our metabolic health, it's going to improve conventional chemotherapy. You mentioned patients will generally feel better. And then a little bit of nuance on that. I've heard that if you do, I think this might just be for fasting, and you could clarify it might be keto as well. But when somebody incorporates that around chemotherapy, they can feel a lot better during treatment. So if they start that beforehand, fast throughout the chemo, and then afterwards, that can help with the symptoms of chemo.
Yes, definitely. So the trials that have looked at that have either used water fasting or severe calorie restriction fasting around chemotherapy, and those patients tolerated chemotherapy better. In fact, in the fasting mimicking or the restricted calorie diet, the patients didn't even take the steroids that are usually given in conjunction with chemotherapy, which then, of course, drive up sugar and insulin. So those patients that were doing the fasting mimicking diet did not have steroids and still had better overall symptom scores. The one that was using water fasting in gynecologic malignancies, they had less need for dose reductions. They had less hospitalization. So definitely can help protect in that state, right? If we think about it, right, we're going to take away that preferred fuel for the cancer cell, but we're still providing the preferred fuel. Now, when we're fasting or using calorie restriction for fasting mimicking, what we're doing is we're pulling fuel for our normal cells from ourselves. We're pulling it from body fat. So we're still eating, but we're eating ourselves. And that may be okay for some. But sometimes we do have quite cachectic patients. That means very little fat and maybe even little muscle, that they've already eaten a lot of themselves. And so in those patients, I find that using water fasting or calorie restriction wouldn't necessarily be the best way to get them into a fasted mimicking state. I would much rather them be feeding their normal cells, feeding themselves good micronutrients, vitamins, minerals, amino acids, fatty acids to get their normal cells operating better while they're going through therapy. So again, yeah, definitely we can improve our symptoms based on the studies that are available. We can improve our outcomes based on the studies available.
Let's talk more about that weight loss piece, because a lot of people, when they first come to the ketogenic diet, it is for weight loss. And we know you've touched on the fact that people with cancer can have a challenge keeping weight on, cachexia. So for somebody that adopts a ketogenic diet, and we can get into a lot of nuance around that, but we'll just keep it general. Talk about over time what happens to the weight, because if there's somebody that is overweight and they go on that diet, they're going to naturally come back to a baseline. But if somebody has cancer and that other element, how does that tend to play out? You've touched on it, but I want to get into the nuances here.
Yeah. When we're using a ketogenic diet, I call it a weight balancing diet, because yes, if you are overweight, it will help you burn fat that you have on your body. When you are underweight, it actually helps you build lean mass. And so we know that there are body composition improvements in patients who follow ketogenic diets. Even in cancer patients, we've seen some of that with increase in lean mass, increased bone mineral density, increased overall mass. So some of our head and neck cancer patients or GI cancer patients that do have problems with weight maintenance, especially during therapies, we've seen on ketogenic diets that they can actually gain weight. So I will say that there are some times where patients need to really focus on getting in adequate calories, getting in adequate fast. Sometimes when you're going through chemotherapy, if you are suffering symptoms from that chemotherapy, a lot of times you just don't feel hungry. You feel nauseous or something where you're not eating. So we have to really utilize the days that we're feeling good to try to build back and build up. But one of the common mistakes when people start a ketogenic diet is they just do a low carb diet, meaning they just start cutting out carbs, but they're not actually eating any fat. They're eating chicken breasts and salmon, which great, fine. But then they're not adding enough fat. So now they don't have carbs and they don't have fat and they have no energy and they feel terrible and they're wasting away because they need to eat something. They need to get energy somewhere. So it is about education. It is about don't fear the fat. It is about choosing fattier cuts of meats and eating whole eggs, never egg whites and things like that, where we're really trying to optimize the fat that they're taking in, which is now going to replace typically a high carbohydrate diet. But not everybody is eating a high carbohydrate diet, but most are.
You touched on the fact that when somebody's going through treatment, they may have a loss of appetite. And just to add to that a little bit, even if somebody is doing the ketogenic diet correctly, including that fat, one of the quote unquote side effects is the fact that they're going to lose a lot of that hunger. So I can imagine when you're working with somebody that it might be even better to have them on some kind of eating schedule to make sure they're getting enough calories, especially if they're, dealing with cancer and there's a threat there of losing too much weight.
We range from everything, right? Because we have very obese cancer patients and we have very thin cancer patients and we have people with great appetites and zero appetites. And so it really is, when we get into that true cancer space, I feel like there's a little more nuance in sometimes, our hunger and satiety signals just don't work properly. or we're really fighting against, healing. Anybody who's gone through a surgery and has to rebuild and repair, we're in a slightly higher use, right? We need more amino acids. We need more building blocks during times of repair. And while we're going through cancer therapies, that's a constant repair process. We're always trying to heal our normal cells in between each cycle of chemotherapy, in between each dose of radiation. So the more we can do to help support our body during that time. And yes, so sometimes it comes to scheduling. Like, I'm sorry, I know you don't feel like eating, and I know you only want to just have this one little drink and you call it a day, but that, like, eating now is your job. Like, this is how we have to do it to kind of pull you out of that hole.
Let's come back to the physiology of cancer piece. And we know cancer is going to upregulate insulin receptors. It's going to want glucose. What I want to get at here is it's commonly known that being obese is a risk factor for cancer. But to me, there's three separate pieces to that. It's obesity in and of itself, the increased insulin that is going to accompany that, and then the increased blood glucose that's going to accompany that. They kind of all go together, but they don't have to. We can have patients that are normal weight and they have insulin problems, and I want to get into that too. But a lot of times those three go together. So when it comes to cancer, again, going back to what we know so far, the fact that they have these increased insulin receptors on the cell surface, they're looking for glucose. How big of a piece is obesity in and of itself contributing to cancer, or is it more just the underlying association to insulin and glucose?
Obesity is kind of what got me interested in this whole piece to begin with, because I was dealing mostly with women's cancers like breast cancer and endometrial cancer, which are very highly associated with obesity. So my whole practice originally was, can I get patients to lose weight, and trying to employ some form of low carbohydrate diets to do that. And it wasn't until I kind of finally put two and two together and, okay, well, why do skinny people have cancer? Is it really about obesity? And then when you actually look, there's data that says even if you're obese or you're normal weight, it really comes down to insulin. It's not about the obesity. I usually say, if you are carrying extra weight, I know that insulin is too high in you at times. It may not be too high. If I did a fasting insulin, it might still look. So after fasting overnight and getting a morning insulin, it might actually look okay. But if you're carrying extra weight, it means that insulin is being active during the day, because insulin is what is creating that fat storage. And so I do think that there's a little bit of a nuance, right? So I'm going to go back to ancestral bears, that bears going into hibernation, they eat a bunch of honey and berries and fructose to create insulin resistance so that they become obese, so that they can go and they can hibernate. And then they can burn that fat, and then they come out and they're back to their thin. And now food is plentiful, so they don't need to eat the honey and berries. So it can go both ways. We can eat in such a way that we create insulin resistance and then we create obesity. But there's also kind of the flip side, in that maybe we're not insulin resistant per se, but we're over consuming. We talk about calories in, calories out, and it's not so much that as that our fake food environment, there's very little protein and healthy fats, and we tend to overeat. We have broken insulin signaling. We have broken satiety hormones, and we tend to overeat. We stuff our fat cells with fat, and then our cells become resistant to that signal. And now we start to get higher and higher levels, even at fasting. It has to stay up all the time to kind of keep things in. But interestingly, there was a study, observational, that came out a few years back showing that, why is obesity seem to be protective in the younger breast cancer or younger woman population? They had less breast cancer, but obesity when you're older, postmenopausal, seem to have much higher risks of breast cancer. And if we think about it from a storage perspective, so maybe we're having ups and downs in insulin, but our fat cells are still taking up fat pretty easily. So we don't need excessively high insulin levels. We're just glucose comes in, insulin is released, glucose and fatty acids are put away. Our cells are still receptive. So then insulin drops back down. So it's only going up kind of after we eat and it's coming back down. But as we do that over and over and over and over, so decades of that, well, now our cells are like, there's no more room at the end. You need more insulin to push and push and push that in. It doesn't happen. So as we age, we become more insulin resistant. So it seemed to go along with that insulin resistance piece where we started to have elevated insulin. But again, the researchers didn't understand that metabolic feature. So they just said, oh, and I was with a group of, breast cancer physicians saying, I don't know what this means. Fat's okay. It's good for you when you're young. It's bad for you when you're bad, being obese. It's like, well, no, that's not. It means we're on the wrong path already. But we tend to get more insulin resistant as we age. And sadly, in our today's population, everything seems to be starting earlier and earlier. So what used to be a postmenopausal disease is now a midlife disease, even an early life disease.
All right. So to try and highlight the essence of what you just got into there, if we are obese, there is an insulin problem and we need to address that. But if we're not, we could still have an insulin problem and insulin resistance building up in the background over years. So insulin is the driver we want to be looking at when it comes to cancer. You touched on the nuances of testing for insulin. It sounds like even a fasting insulin test can give us a false reading depending on where the person is along their journey. So what I'm getting at here, given it all comes down to insulin, and we really, as an individual, whether we're obese or not, we want to be aware of that level and what's happening in the body. What's the best way to test to get our baseline?
So I always still recommend getting a overnight fast set of blood work on a routine basis. And if you're otherwise healthy, you might only do that once a year. Others might need to do it more routinely. But I will look at not only insulin and glucose, but also the interaction between the two. So there are some calculations that we can look at. I will also look at fasting triglyceride levels. So triglycerides are the fat that's in our bloodstream. So we have, again, two fuels, glucose and triglycerides or fat. And if both of them are elevated, there's a big problem. If one of them are elevated, there's still a problem. But again, it's the balance between the two. And I will also look at triglyceride HDL ratio. So HDL, one of the cholesterol markers, but triglyceride divided by HDL is another way that we can look at insulin resistance. So I try to look at all three and in everybody. And those three can give us some guidance. If any one of them are abnormal, again, in my range, not in a conventional range, then we know that there's some degree of insulin resistance. If all of them are normal, but I have signs in a patient, maybe they have a lot of in-between meal, hunger, anxiety, like they have a lot of the symptoms, the hangry symptoms that people will often comment about. But if they can't easily skip a meal, many people don't want to skip a meal, but if they had to, they could, and they would still be functioning fine. But if somebody is walking around going, I need food right now because I think I might die, that is a sign of significant insulin resistance, actually. Insulin is still on and pushing that glucose down. So I do have some people, typically in my younger population, that still have fasting numbers that look okay. But when you really question them about how do they feel, what about brain fog, fatigue, all of these other symptoms, then you think that there's probably something hiding in between the fasting numbers. And And there are ways to check. We could always put a continuous glucose meter on somebody. We could do a postprandial insulin. I tend not to do those because it's a little hard to time in a lab properly, but there are some ways to know. The other way to do it is, hey, change your diet, see how you feel. Because guess what? All those things tend to go away once we stabilize somebody's blood sugar.
I could see how somebody could make the argument that if they have the genetics that when they're consuming too many carbohydrates and they're putting on weight, that could actually be a good thing because they have an outward appearance change that's going to trigger that something's awry versus the person that genetically can build up insulin in the background and continue to produce more and more, have insulin resistance, and then end up potentially, getting something like cancer or another chronic disease, and then finding out they have a problem that way.
It is a tough one. I think that our vanity, is something good. I think that when we put on excess weight, I think most of us are like, oh, I wish I could take off that 10 pounds, that 20 pounds, that 100 pounds, whatever it is. And so I love it when people come to a ketogenic diet for weight loss because it is a powerful motivator. But you're absolutely correct. How many skinny people are out there that say, I can eat anything, it doesn't matter. And they do eat anything because they think it doesn't matter. And I am constantly trying to remind people it is not about weight. It's about health. It's about what are your cells doing. So even if you're thin, most thin people will still have some complaints, joint aches or brain fog or something else that gives you the clue that they still have some issues going on with their metabolism. But let's say they feel great, they think they look great, they're exercising great, they think they're eating the best diet. There are ways to look. And certainly we can do my lab testing. There's more advanced testing where you can do DEXA scans and actually look at visceral fat because sometimes they don't have a protuberant belly. They don't have a beer belly. But they do have significant visceral fat in their belly. And that's a sign that we have insulin resistance problem. I always say getting a blood test is cheaper, faster, and only if it doesn't give us the answers we need, then, do we need to go to a more advanced test?
So if somebody were to come to see you, whether they have a belly or not, you do the testing, you find out their insulin is running too high, and they adopt a ketogenic diet. How long does it take for the insulin to start correcting itself?
It varies, and it also varies on how a patient structures their diet. So even though I give them instructions, not always are they followed 100%, right? For some people, it's extremely new and overwhelming, and they're making small changes, and we just keep kind of refining. But I have seen fasting insulin drop very quickly. I think that if you have not been insulin resistant for your entire life, then it comes down quicker. So I feel like sometimes younger folks or folks that just started noticing some of these things, I tend to have a much quicker reversal. Whereas people who have been, maybe morbidly obese for decades and their insulin is quite high, 10 times, not quite, maybe 10, but at least 5 to 10 times higher than I want to see it. Sometimes that's a much slower process. And sometimes we have to look a little bit further than just food. We've talked about, it's not just food, but maybe it's environmental toxins that are estrogen mimickers that are driving insulin elevations. Maybe it's sedentary behavior. We know that exercise and various forms of exercise can help with that. So when I see a patient, even though my main focus is working on their diet, it is still trying to optimize their other pieces. How do we optimize sleep if that's an issue? How do we look for toxins in their environment if they've never even thought about it before? How do we add in exercise? Going from someone who only walks to can we do something more than walking on occasion?
I'm glad you brought up these other aspects. And throughout our conversation, I want to dive more into some of them. But coming back to the diet piece, so insulin resistance, it sounds like it's generally correctable, but you gave the example there of a patient that's been obese for a long time. Say you see, well, basically what I'm getting at here is, do you see people that have been overweight for a long period of time, producing too much insulin, blood sugar, running awry, where their pancreas is so beat up from that and doing that for so many years that they can't correct the insulin? Or is there hope for, have you seen that with a
There's hope.
patient? Okay.
There's hope.
I think it's important we get into the hope piece, because somebody might be tuning into this and they're 70 years old and they feel like, I've been overweight since I can remember. And I know that my insulin's been all over the place and my blood glucose. And I want to give them hope as well, that they can still make these changes and correct the underlying challenge.
Absolutely. I see that even most people coming to me have never had an insulin checked. So they know that their sugars are high. They know their hemoglobin A1C, which is a quote unquote 3-month average of glucose, might be high. So they know they have either prediabetes or diabetes. They may tell me, I've tried every diet in the book, nothing works, right? So now we have to say, okay, let's look under the hood, because I think sometimes when they see these numbers and I say, this is why you can't lose weight. You have a fasting insulin of 20. Like, you are on high storage mode. So we need to get that down, down. I like to see it less than 4. So how do we move that in the right direction? So first is, let's create a ketogenic diet right for you. And many, many times patients will just go on low carb diets, which are also low fat, and then they may never break into that fat burning. So I have seen patients that until I got them eating high fat, they would not lose weight. As soon as we got them eating high fat, they started losing weight. I have seen patients who constantly calorie restrict, but so they're eating 800, 1200 calories a day. And if you're eating that little, your body thinks, that hibernation is coming, that a famine is coming, and that your body naturally will try to hold on to that weight because it doesn't think more food is coming. So we really have to play into getting our body being happy, healthy, and feel like there's no care in the world, that everything is going to be hunky-dory tomorrow, because it's remaining in that fight or flight mode that really can hinder results. So there are some folks that I struggle getting their insulin down, even though I've had some lose weight. Their weight is going down. They feel great, and their insulin's still high even. So there's all kinds of folks out there. And what we have found with some is that by putting a continuous glucose meter on them, we start to get some more information. And some people, I feel like, are pushing the intermittent fasting thing a little too much, and it's actually creating more stress to the system. And that when they actually eat scheduled meals, they do better. Or maybe when they remove dairy can be inflammatory in some people. So again, it's really trying to work with that individual. But I always say it's never too late to start. I even have a 90-year-old that I'm working with that has had wonderful results in her cancer results without actually getting to conventional therapies, because she was on hospice, or I shouldn't say that. She was encouraged to go on to hospice, and she said, no, and I don't want your chemotherapy. And I'm just, and she had a bad ovarian cancer and was swelling because of ascites in her belly, and her tumor markers were going up. And we just tried to end her cachexia. So she was wasting. Her muscles were we could see it in her protein markers. But we got her on a good ketogenic diet, encouraged her to eat every 2 hours, actually. And all of a sudden, her protein markers are looking better. Her fluid is less. She's getting less draining. She's out in her garden working, and her tumor marker dropped about 50% just by changing what she was eating.
You touched a bit there on the low carb versus keto, and the example of somebody not having weight loss success until they include more fat. Let's get into the nuances there a bit more, because a lot of people tuning in might be saying, okay, isn't low carb naturally a ketogenic diet? Because a lot of times what a practitioner will tell a person is get your carbs down below this level. And that is a ketogenic diet, whether it be 20 grams a day, 50 grams. There's variance there, I'm sure, between practitioners. So let's talk about the difference there in more detail.
So just lowering carbs it can temporarily make ketones in some people. So it may or may not be a ketogenic diet. And you don't know unless you actually test. So is that patient making ketones? And I do have some people who go on a low carb diet, maybe not to the degree of fat that I want them on, and they are making ketones. So if we were only using ketones to judge, we might say, yeah, they're making some ketones. That looks good. Their glucose is not bad. But unless that insulin is coming down, then that's still not the state I want them in. So it's really looking at all those pieces. Is that the depth of ketosis that's needed for you? Maybe you need more fat. So I usually recommend that we do optimize the fat. Again, especially for somebody who is in a weight loss, like a cachectic type, they absolutely need to. But interestingly, I have heard a number of patients who've told me that, yeah, until I optimized my fat, like I just wasn't losing weight, or I wasn't optimizing my calories. And again, I'm only using calories as a surrogate for fat almost. But it's like if you're just eating too lean, right? So if we're eating low carb, but we're not adding fat, then really what we're doing is we're eating a lean protein diet, and maybe it's fatty protein, but it's just not to the degree of fat. So we think of, steak and burgers as being fatty, but they may not be that fatty. Obviously, chicken breasts are very lean, and even fatty fish like salmon are actually pretty lean when we compare it to maybe a prime ribeye or, butter. So when we optimize that fat, let me back up. Sorry. So eating too lean. So when we eat protein in the setting of kind of that lower carbohydrate diet, we do get some insulin response. If we're eating protein in the setting of a ketogenic diet, in the setting of a fasting mimicking state, we actually don't drive insulin in the same degree. So when we look, there was a ketogenic ratio that was published a number of years ago, and fat is essentially all ketogenic. Protein is about 50-50. Protein, insulinogenic versus ketogenic, and carbohydrates are almost all insulinogenic. But you can imagine if you took away the carbs, okay, I'm going to take away that insulin part, but I'm also going to not optimize my fat. And now I'm left with mostly protein. Well, that still is not as good as a protein fat mix. That protein fat mix is really the sweet spot. And then the rest of it is just window dressing.
Got it. So we know insulin, again, coming back to our major theme here, is a big piece of this, arguably the biggest piece. But when we start talking about low carb versus ketogenic diet, it gets me thinking about ketones specifically and their role in cancer. So we know, going ketogenic is naturally going to bring down glucose in the blood and bring down insulin, which is good. We're going to produce ketones. Does that add additional benefit when it comes to cancer?
We do think that ketones have some direct roles in cancer, in healing of cancer, in addressing these metabolic or what we call the hallmarks of cancer. So all of these different things that a cell has to be able to do to be a cancer cell, to, can it metastasize? Can it grow? Can it create its own blood vessels? Blah, blah, blah. Ketones appear to have some direct effect on all of those hallmarks, which is great. My only reservation with that is just like with anything, is it truly the ketones themselves, or is it the state of being in a metabolic process that produces the ketones? Because what drug manufacturers see is ketones are what we need, so let's go make a product that we can just give people ketones, and they don't have to do this very restrictive diet, which is really just eating real food and how we were naturally meant to eat. So I don't find that very restrictive. But that being said, there's some data out there. They're starting to investigate, should we be adding ketones? I don't know that data is clear at all. And so my bias is we should be in a state in which we produce ketones and not take ketones.
Well, when you talk about a drug to make ketones or a drug that would be ketones, it gets me thinking about natural ways of doing that too, which is MCT oil or exogenous ketones. So for somebody that is adopting the diet, say they're getting endogenous ketones produced, but they want to bump that up using a natural form, have you seen any success doing that?
I don't have enough direct comparisons. Do I have people using MCT oil? I do. They use it more as a way to get fat in, as opposed to truly a way to make ketones. And there are some people where I almost don't, I'm not sure on exactly what is going on, because I have people where I just couldn't get their insulin down, but yet I'm looking at their ketone levels going, why does this look so good? And, oh, you're taking a bunch of MCT oil. So I'm not, again, do we know what the magic level of ketones should be during various therapies? I don't think we know. It's not really measured per se in most of those trials. It's eat this way, do this, fasting, do this. Some of them are testing, but they're not saying we have to be at a certain level. And might one level be okay? Again, I come back to labs. I have some people who are only making ketones in the 0.5 to 1.5 range. But yet every time I measure, they're more insulin sensitive, more like every lab keeps looking better. Their inflammatory markers are going down. Everything looks great. And they're never in that really deep state of ketosis as a Dr. Seyfried would, kind of want to say that people need to be in. Whereas others are in really a moderate state. They're 1.5, 2.0s. And their insulin is just sitting where it is. So I always have to come back and say, okay, are they just getting their ketones to that level because they're taking some MCT oil and they're not actually making the metabolic changes that I need them to make? So I use those very strategically. I'm not a huge fan of just dumping them in. I think those are areas where we definitely should do more research, because I'm not convinced that they work the same way as following a ketogenic diet and breaking down our fats the way that nature intended. What is an MCT oil? A refined coconut oil. We didn't have any refineries back in the day, so we wouldn't have done it. So I'm not saying that they're not beneficial, and I do use them strategically, but I do start to get a little bit anxious or cautious when I'm seeing disparate numbers. Ketones are higher, but we're not really moving insulin the way I want to.
You mentioned Dr. Seyfried there. He's been on the show a couple times. And to synthesize his message down in the simplest form, it's to starve cancer of glucose and glutamine. And while we're talking about ketones and the benefits of them in the ketogenic diet, it gets me thinking about tying that to Dr. Seyfried, different fuels for cancer. And what I'm getting at with that is I've heard the argument that ketones can feed cancer. Any research you've seen around that?
Yeah, I know of two studies that show. One was in a cell study. So cells grown in a gel, in a dish, are not the same things as cells that grow in our very complex metabolic body. But very interestingly, that medium that they were growing the cancer cells in was a high insulin medium. Well, of course they were going to grow because they had insulin. So that one I threw out. Okay, that's a non-issue. There was another one, which I believe was in animals, and they gave, I think it was in animals, they gave a very high dose of acetoacetate versus a very high dose of beta hydroxybutyrate. So those are two different ketone bodies. And actually, when they gave the high dose beta hydroxybutyrate, which is actually what most of our ketone supplements are currently, there was no growth. But when they gave the acetoacetate, there was growth. So all I think that and they were quite high doses too. So I come back to, we don't want to overfuel any tumor. So we certainly don't even want to, we don't want to overfuel our own cells. We want to live in a nice balance. So I don't see any of the data that beta hydroxybutyrate or being in a ketogenic state would grow cancers. There is a little bit of caution, I think, when we're adding excess in, so not naturally produced. And I always come back to the MCT oil of, well, is that naturally produced or not natural? I mean, our liver's producing those ketones from a fat, but that's a little bit different than using long-chain fatty acids for metabolism, which does have different metabolic properties in the cell and how it turns on and off insulin. So I still will always go back to, I'd rather people eat a real food, saturated fat type ketogenic diet than add in these other pieces until we have more information. But again, if somebody can't eat and we're trying to make a smoothie and just get some fuel into them, we might add some MCT oil. We know that ketones can be muscle sparing, can, have some other favorable metabolic effects, but I think we have to do it with caution.
Up until this point of our conversation, we've really focused on mitochondrial health and metabolic health and building the body up that way to prevent and treat cancer. How do you feel about looking at it from that other perspective of starving cancer? We know that no matter what, even on a keto diet or fasting, we're going to always have some level of blood glucose. Although for fasting or in a ketogenic diet, it's going to be a lot more stable. But again, tying to Dr. Seyfried's work on starving cancer, and there's a lot of people in the natural health realm that talk about starving cancer. How do you feel about that?
I think that's what we're doing to some degree. And I think that a small proportion of patients may actually have success doing just that. But I think that when we look at the available data in animals, because that's where we have most of that data, that's not enough. But again, how was it designed and how was it, most of the animal ketogenic diets are still like soybean oil and processed chow and, so not an optimal diet. But it was combining that starvation piece with oxidative therapies that seemed to be kind of the 1-2 punch. And maybe, as I know a lot of folks out there are trying to look at, do we need as aggressive of those oxidative punches? Can we do lower dose or lower volume or other pieces to that treatment? But I do think that, so if you look, I was trying to review a biochemistry slide, which I thought was quite interesting. So yes, when we have glucose available, right, we're trying to stimulate insulin, pull the glucose into the cell. When we have very low glucose, low insulin, and we're burning long-chain fatty acids, some of the breakdown products of long-chain fatty acids actually further block insulin. They lock it out saying, hey, we have enough fuel in this cell. Don't send me glucose. I don't need it. So there's like further starvation of the cell when we are burning that long-chain fatty acid for fuel. Interestingly, and maybe Dr. Seyfried knows more on this, but I was trying to read up on the glutamine piece, and what I was seeing was that ketogenic diets, very low carb or carbohydrate restriction and starvation may actually also lower glutamine. And then also that when you're in a ketogenic state, you're actually converting more glutamine to GABA. happy hormone. So we're pulling, hopefully in a ketogenic state, not only are we providing less glutamine, we're also converting more of it out of a glutaminic glutamine state. So there may be some really interesting, again, biochemistry that's going on that we just are not fully aware of yet. I think that it's a very fascinating area of investigation, but just like with glucose, glutamine is necessary for our survival. We can't ever get to zero. We will make it. That's why we have all these built-in backup systems that if we don't eat these foods that contain it, we will make it. So we'll make it somehow. And very interestingly, in a cachectic state, so somebody end stage that's actually a highly metabolic state. Glutamine goes through the roof. And, so if we can just quiet, if we can turn the switch around, we're actually probably taking that glutamine way down by putting them in a ketogenic state where we're stopping the cachectic process.
Interesting. You used a term there, oxidative punch. What do you mean by that?
So those would be anything, that's going to provide that additional stress. So that would be radiation or chemotherapy or immunotherapies or hormonal therapies. But also if we go into the natural world, is that the high dose IV vitamin C's, the hyperbaric oxygens, the hyperthermia. So there's a lot of potential oxidative therapies that exist both in the quote unquote natural or alternative world as well as in the conventional world. And what would be really great is if we could come up with a way to kind of minimize or also identify. I think that just like with chemotherapy that's given very cookbookish, you have this disease, this is what you get. They're starting to do a little bit more of looking at certain genomic changes and, okay, you might be better off with this or this. But the same goes for our alternative therapies. Oh, you want high dose IV vitamin C? Here's your regimen. Is there a way to maybe look at people in a ketogenic state, in this optimal state, and can we do things differently? It would be really interesting, but unfortunately, there's not a lot of money in it.
Well, let's talk about some of these adjuncts. We know the keto diet is the basis here. We've gone deep into that, but how do you feel about IV vitamin C? Is that something with patients you use alongside the diet?
So I don't do any adjunct therapies at this juncture because I am fully 100% telehealth at this point. I do work with patients on nutritional supplements and other things that we can do at home, testing they can do at home or other treatments they can do at home. But from an IV vitamin C, I think that there's just not as robust data because the conventional world doesn't study it. And when they do, they don't always do it the way that it should be done. And so then it looks like it's terrible, and it's not terrible. A lot of conventional medicine docs think of IV vitamin C the same way they think of oral vitamin C. And they are like, oh, don't take it during treatment because it will protect the oxidative stress from the chemotherapy. And you're like, no, it's a different process. It's, so I have patients who use it. I don't ever tell a patient which treatment regimen they should follow. I now work with patients to kind of find out where they're coming from, what types of therapies are they investigating? Are they absolutely against or definitely want to include? And I try to just optimize them. And then we test. And if I'm seeing numbers going, completely wonky, then I might say that therapy may not actually be right for you right now. Or maybe you need a break. Maybe you need more healing. Maybe, so I'm just trying to give them a second opinion, a counsel, a sounding board, questions to ask their providers, and really try to work with them on the foundation.
So if a new cancer patient came to you, and again, there's a lot of nuance to this, what type of cancer stage and so on. But if they were inquiring about IV vitamin C, hyperbaric oxygen, you mentioned hyperthermic therapy, what do you tell them if they start probing and asking you, should I include these? How do you feel about them?
I totally let them do. I think there's a huge placebo effect too in almost all therapy. So if they're walking into the chemotherapy office thinking this is poisoning me and killing me, it very well could. Whereas if they're walking into the IV vitamin C clinic saying this is healing me, this is curing my cancer, this is like, that could be very powerful. So again, I try to advocate for let's look at everything. So let's look at your labs. Where are you? Where do we need to go? Maybe you shouldn't do anything yet because you're not healthy enough to do any therapy. Let's just get you healthier first. Then we can start talking about different therapies. But if somebody wants to, I just say, please find a reputable provider, talk to them. There's certain tests that might be done before offering treatment. And if they're not checking those things, then I think maybe that's not the place for you to go. Like if they're not asking these questions, then, so I do try to coach them as to what things they should be looking for. And then we just continue to monitor. How are your tumor markers doing? How are your inflammation markers doing? How is your insulin resistance doing? Like all of those pieces. And most of the times we might pull certain things in and pull certain things out. And anytime we're seeing worsening in something, well, then what you're doing maybe isn't working for you. Maybe it's time to rethink. Maybe we need to change direction.
Again, using our hypothetical, somebody with cancer working with you, and they've adopted a ketogenic diet. They're working on their mitochondrial health, their metabolic health. They have that baseline, but they want more. We already talked about the adjuncts there, the hyperbaric oxygen and hyperthermic, and what was the other one? There was 3 there.
Well, we did
IV vitamin C. That's it.
Yeah. And there's others. There's mistletoe therapy that's out there. Which is not quite as oxidative. That's more gently healing, right? Trying to help the body with its own immune function.
Okay. Where I was going though is supplement wise, things they can include specifically on top of that diet to have additional benefits.
This is where I start to diverge from some of the complementary or alternative natural docs out there. Is I am less about adding more supplements because they have this antioxidant property or this tumor pathway blocking property. I treat that no differently than I treat a pharmaceutical. Like that is, okay, what are we trying to do? We're trying to put a Band-Aid on a problem. Let's get back to the root of the problem. So I do recommend some supplements, but they're almost always nutritionally based supplements like vitamin D or omega-3s or something where I see deficiency in the system. And we're trying to kind of prop up that deficiency until we're where we need to be. And what I see is a lot of folks coming in on 20 different supplements because they read a book and watched this person's podcast and listened to this. And I'm thinking, I don't think, well, number one, they've never been studied together. So you're assuming that they're all going to work as they would in an isolated capacity. In addition, in the isolated capacity, we don't know how those people were eating. We don't know what else they were doing. Just like if you had hypertension and I put you on a blood pressure medicine, your blood pressure would go down. So therefore, a blood pressure medicine is what you should take for your blood pressure. But I would say your blood pressure issue was caused by insulin resistance, likely. So let's fix that. And now we don't need the blood pressure medicine. So I'm very much an anti-supplement person, although I don't prescribe anything. I recommend, I discuss the whys. I think that there are a number of folks out there who have what we call the MTHFR mutation, a methylation deficiency type gene, that sometimes they need help with methylation. So some of those, but again, I'm just trying to get all the pathways to be optimized. I'm trying to get those micronutrients optimized. I'm not trying to add pathway blockers or, and a lot of those. So we hear about antioxidants. So just maybe no one's heard this. But when we give one of these compounds in a high dose, right? So these extracts, maybe it's resveratrol or EGCG or something, they often are creating inflammation in the body, for which our body responds with our anti-inflammatory response. So maybe in the short term, are we creating a little hormetic stress that stimulates our response? But if we take that same thing now every day for the next 3 years because it's supposed to help me with my cancer, I think that the data is lacking, and I think that a lot of times we're a little bit misguided. They were used for very short periods of time. Maybe it was a couple week trial. We don't know what numbers were before or after, what happened 6 months later. I always just keep going back to that cellular health and getting all of these processes, all these micronutrients, trying to optimize those so that our natural healing abilities are restored.
Well, the good news in all of this, it keeps coming back to, again, building up the mitochondria and metabolic health, which makes it a lot easier for people, whether they're in the prevention category or if they have cancer and they're battling. So what I'm gathering there from that last answer, reading between the lines, is that either way, when it comes to adjuncts to the diet, you're looking at just supporting the system and bringing it back into balance.
Absolutely, 100%. And that goes, for, yes, prevention and for the cancer patient. And again, I might do things a little more stringently or aggressively. There's some people who have plenty of time. Let's just do this baby steps, move in the right direction. And others, it's like, you need to do all of this today, and get you moving in the right direction as quickly as possible. So it's more about the speed and the urgency as to how I work with patients than truly what I'm recommending, because what I'm recommending is almost always the same.
Let's talk more about that speed and urgency piece, because for somebody that finds this interview, maybe they were just diagnosed with cancer and they're getting pressure from their doctor to, pick a path and jump on, say, chemotherapy or a different conventional treatment. What would you say to them if it's a family member and they're just diagnosed? And again, I always like to caveat this. There's a lot of nuance. Obviously, it depends on the stage and what kind of cancer. But I think a lot of times people just feel an immense amount of pressure when they get that diagnosis and stress, and maybe they don't make the best decision under that pressure. So what would you say to them?
Number one, cancer did not happen overnight. So it is very likely that you have time to take a step back and to think about what your options are, to get a second opinion, to, read some books if you want. But unless you are in a critical state, you have a brain tumor that's squishing your brain stem, well, obviously that's an emergency. You have a colon cancer that has obstructed your GI tract. Yes, that's an emergency. So there certainly are some emergencies where you need to act immediately. But most cancer diagnoses are not an emergency. Some might be an urgency, right? That stage 4 cachectic patient, we really need to kind of get things moving. But it doesn't mean you have to jump into treatment. It just means you need to jump into activism. You need to do something now. Let's work on what that is. But somebody I see this, it's the MO, because conventional therapy doesn't think there's anything out there except for conventional therapy. There's nothing, you can't heal yourself. That's not possible. And your other alternative therapies will just see you later with worse disease. And they only see the ones that come back with worse disease, but they don't see the ones who healed themselves and went off on their merry lives. So we don't always see both sides of the story. And so I think that there is an urgency from the conventional world that this is only going to get worse. So we want to take care of it at its earliest stages where we have the most tools in the toolbox to use. But I usually tell patients that I'm working with, let's, take a step back, take a breath. Like, where are we? What are your goals? What do you want to do? Some do want to do some healing first. Others, it is the fight or flight. Their fight is to go and start conventional therapy right away. We'll do whatever you want to do, but I'm doing this tomorrow. okay, let's do it. Let's just support you through whatever choices it is that you're going to make. But I try to help patients gauge like where they are in the spectrum, because I think that when you hear the word cancer, you think, I'm going to die, and that could be, couldn't be further from the truth. Like most patients are going to do quite well and have many, many years. And let's see what we can do to optimize that. But again, I do try to give patients a little idea of their degree of urgency and what they want to do. And do they want to get a second opinion? Do they want to, again, what do they look like under the hood? Because some people do look pretty good already. Why did they get this cancer? Do we, think of a certain stressful life event that maybe tipped the balance, or some other injury or infection or something that, again, tipped the balance? And so what can we do? But I work with patients that come from every walk of life and every mindset. And I do have plenty of patients that are, there is some value to our conventional medicine system. So we don't want to just throw the baby out with the bathwater. We just want to say, what can we do to optimize it? What can we do to optimize ourselves? What things do we have to do? And what things, do we not have? And I never say anything is a have to. That's always a patient decision. But I'm always trying to go through pros and cons of, all of their choices so that they get it's an educated decision. And I get really kind of bothered by documentation or statements by conventional medicine doctors that say, oh, the patient will benefit from X, because studies have shown a 50% benefit. And I'm like, well, then that patient only has a 50% chance of benefiting from that. That's not a will benefit. That's you might want to consider it. That's a really big benefit. But if it's a 3% benefit, like, why are we not having these conversations of what do those numbers really mean for the individual patient? And that's what I try to break down for them a little bit more as to, this is you personally have a 1%, 3%, 50% chance of benefiting from that treatment. So are the side effects or the risks that go along with that worth it to you? And let's figure out, if they are, what are we going to do to optimize you?
You talked about stress there, and this ties into getting the diagnosis and thinking I'm going to die. I can only imagine what kind of stress that would be to get a diagnosis like that. I'm sure only somebody that's been through it can relate to what that's like. But what I want to get into here is the stress piece, and especially getting a diagnosis like that in and of itself is going to cause a major stress to the person and their routine and their sleep. And you could see how this would just compound, and feeling the pressure to begin treatment and how am I going to pay for everything? And I'm probably not even thinking of half of it. There's so many different things I'm sure that come up, and so much stress that I can imagine a big part of your role is to help people with that. So talk about the impact of stress when it comes to cancer, and how somebody who has just been diagnosed and stress is through the roof, how they can go about managing that, we'll say.
Well, number one, I do find that patients who are most metabolically broken tend to get the most stress with they just don't have that regulation. So that cortisol really jumps up, the glucose and insulin really jump up. That being said, what I try to do is reframe the issue, right? So they hear cancer, I need surgery, chemo, I'm going to die. I hear your body has been screaming at you that something has been broken, and somehow you just haven't listened over the course of the years. Like you didn't know to listen. This is your 2-year-old throwing a temper tantrum. But instead of just kicking them out of the house, you need to get down on your hands and knees and say, tell me, what are you trying to tell me? Like, what is wrong? What is not right in the system? So I always say this is just your check engine light going on. This is This is your body saying, hey, I finally had to throw down this really big, scary word at you so that you would stop and listen, so that you would stop and look. And so now let's just work to see what is out of whack and what can we do to help you bring balance back. And then do we get you into a position where either you now have something to control. I think one of the biggest stressors of getting a cancer diagnosis is you no longer feel in control. And I think that many patients walk into their oncologist and say, what can I do? They want something that they can hold on to, that they can control, that they can start participating. And unfortunately, so many times they hear nothing. Just go ahead and live your life. Don't worry about it. So I think that giving people control is a huge motivator and a huge stress reduction piece, because they finally can put those energies into positive and not into the negative.
For somebody with a new cancer diagnosis, again, wanting to take control and do what they can, I can imagine this ties into the stress. What would add to that stress is to start Googling online and learning more about cancer or their diagnosis. What I'm getting at here is there any good resources, whether it be books or websites, that somebody who has been diagnosed can go and check out? And I know you have a new course that we're going to link up below with Dr. Westman that's all about nutrition and cancer, which is phenomenal. I went through the whole course and it's great. But what other resources for somebody that feels like they have a lot of time on their hands in relation to what they can do to help control cancer? What would you tell them?
So there's a couple of great books if they just want to be kind of more educated on the process of cancer, like Dr. Fung's The Cancer Code is a nice one. Travis Christofferson's, Tripping Over the Truth, looking at the metabolism piece. Dr. Seyfried's book is a textbook, and most lay people probably won't get as much out of that one, although I have a number of patients who say they have it and they've read it. But the one that I really recommend to people is Dr. Nasha Winter's The Metabolic Approach to Cancer. I think that is a really nice overview. Now, she calls them her 10 terrains. She has different, what she calls buckets, which would be stress and environmental toxins. And you can go through hormonal, etc. But really the foundation of the whole process is still mitochondrial health and ketogenic diets. Because if we optimize that, we're balancing hormones. We're decreasing stress. We're like people all of a sudden start sleeping better. They actually start to want to move and do exercise. So I feel like it just is like the basis. And so it's a very nice book because I think it's comprehensive, not only of diet, but of all of those other pieces that really do seem to improve when we get that basis down. So that's usually my one go-to. But yes, anybody that wants to, hopefully the course will be ultimately, we just finished the first launch of the course. They will be putting it up where we'll be able to get new folks enrolled in the course going forward. So folks would just need to join the wait list for that. But that is a nice, relatively quick, it is 4 hours or so of modules, lessons and modules, and then 3 hours of question and answer period. So it is 7 hours of content that really tries to address the why, in the prevention and the treatment, as well as the how, and then tries to do the myths, because I think that's where we get into trouble when we get to Googling cancer, and there's so much out there, and so much of it is actually myth. And I'm always trying to say, where's the level of the science before we jump into something? And we have to ask ourselves questions too. What population was being studied? How were they being studied? Were they following ketogenic diets or not following ketogenic diets? And what we might define as a ketogenic diet, because if you see in the lay press, often we'll see some negative report on a high-fat diet and then they'll put kind of in quotations, like a ketogenic diet. And then you look at it and it is not anywhere close to a ketogenic diet. It's just a high fat, high carb diet, which is terrible for absolutely everybody on the planet. So I think that I tried to, I try in my own practice constantly to address some of these myths that are out there. And I do try to come back to science. What do we really know? Where are the gaps in our knowledge, so that I can't say emphatically, you need to do this, you have to hit this number, you need to do this. I don't do that. I say, this is what I know, and this is what I don't know. So let's just work to get us both moving in the directions that we're comfortable with, that appear to be helping you and not harming you.
Being immersed in this health world now for so many years, I feel like the person that is diagnosed with cancer and they go and do a Google search, they're going to fall into two camps of routes that they could take in the natural realm. One being the ketogenic diet with meat and animal products, and the other being the plant-based world and the vegan diet. So you talked about science there. Let's talk about what science... We know how you feel about the keto with including meats, but for the person that falls into that other camp in their searches, what does science show when it comes to plant-based eating and fighting cancer?
It shows almost absolutely nothing, but I will go over a couple of trials. So there is a trial in a breast cancer population where they were, told to eat low fat, and when you eat low fat, you have to exclude a lot of animal products because they are high in fat. So just by the nature of it being a low fat diet. But guess what? They also got rid of processed foods, right? Because ice cream and pizza and donuts are high fat. So they actually ate a cleaner diet. There was a small survival benefit in ERPR negative breast cancer patients, but a similar trial done at the same time, published within the same year, I believe, or at least a year off, showed no benefit. So again, it was a very small benefit. And if we look at it from a metabolism point of view, okay, we just removed all the high fat, high carb foods. And yes, we stuck with the low fat foods, which typically are more plant-based, whole grains, legumes and fruits and vegetables, etc. But we know that just by doing that, there is randomized data that shows that can lower glucose and insulin in some people. So what would have been more interesting in that trial had they tested insulin before and after, and who were the people who actually benefited? Were those people who ended up lowering their insulin or not? There was another study in prostate. We get to hear it a lot in prostate. We can't eat red meat or eggs, and that's because there was a Dean Ornish trial that looked at doing a very low fat plant-based diet, but he looked at 5 other things: exercise recommendations, supplements. He supplemented omega-3s and vitamin D, and I can't remember the other pieces. There was a support group. There was like weekly phone calls with the dietitian, and there was meditation, so that was like all of those pieces we talked about from a mitochondrial healing, stress reduction and exercise, and, cleaning up or kind of, filling in the gaps of nutrition. And there was a slight advantage, barely an advantage, but a slight advantage. And so that gets talked about quite a lot. Back to, were those the people who lowered insulin or not? When we compare a ketogenic diet to a low-fat diet, to any other diet, a ketogenic diet will always do better at lowering glucose, insulin, triglycerides, raising HDL, reversing metabolic syndrome, reversing diabetes, reversing obesity, you name it. A ketogenic diet always wins. So a low carbohydrate diet just seems to be far, far more powerful. And in addition, we have essential amino acids and essential fatty acids. And a ketogenic diet is robust in amino acids and fatty acids. And a low-fat diet, plant-based diet, is sadly lacking in those as well as other micronutrients, heme iron, B12, omega. Well, you can sometimes get omega-3s because sometimes the plant-based folks will still take in fish or something. But again, I think that when we look at it as a whole, I think the data continually supports the best diet at improving insulin resistance, which is a ketogenic diet, hands down.
All right, we got to go deeper into one piece you brought up quickly there, and that was the Dean Ornish study. You mentioned eggs and red meat, and they're tied to cancer, prostate cancer.
I wouldn't say they're tied to cancer.
No, but you made the statement that that's the myth. Yeah, let's break this myth, because a lot of people tie processed meats and red meats to cancer as a whole. So for somebody adopting a ketogenic diet, naturally they're going to take in, I shouldn't say always, but in general, they're going to be taking in quite a bit of animal protein. So that would be a concern if that myth was true. So can you debunk it for us?
Yeah, well, so number one, when we've actually looked at prostate cancers, so insulin and IGF-1 are big drivers or associations with prostate cancer. What we know that when we follow ketogenic diets, there's actually randomized trial data that we lower insulin and IGF-1, and those are people eating predominantly. They actually looked at their diets, eggs, red meat, all of those foods that we think are a problem. So again, in a ketogenic state or in a low carb, high fat diet, red meat does not drive up insulin. It does not drive up IGF-1, nor do eggs. When the Cochrane Review looked at all of these things, they couldn't find a link between any of that and prostate cancer. When we've looked at observational studies, just on, if we go back to the fruit and vegetables, there's actually no improvement. And even there was one study that showed worsening prostate risk with intake. So observational studies are terrible. We have to look at mechanisms. So what drives cancer growth and what foods can drive those markers or those drivers up. And so, yes, when we do a low fat diet, there are some people who will lower insulin and lower IGF-1, although not as dramatically or as numerous. So as many people will do it by doing a low carb, high fat. So it's about mechanism. It's not about the individual food. So, I can't tell you how many different myths I've heard, but again, always go back to the study, if there even is one, and sometimes it's just mantra. I'm just going to say this statement and I'll say it enough, everybody will believe me. Sometimes it comes from a study, but now you have to look at the study. Was that red meat in the setting of, meat, a spaghetti and meatballs counts as meat, and a hamburger on a bun with ketchup and mayonnaise and French fries count as meat, or are we talking steak and broccoli? Do eggs? Are we talking scrambled eggs, or are we talking ice cream and donuts and pastries, which are all made from eggs? And almost always, if the study doesn't sound right to me, it's always because they include a whole bunch of processed garbage as their food. So it's not the actual food itself. So if we could just go back to studying steak and eggs, broccoli and salad, we'd probably do pretty darn well.
Okay. How do you think about steak and eggs versus, say, like sausages, salami, pepperonis, things that are more processed?
So I think that we don't have to be adamant about not excluding some of the cured meats. I think that curing meats were probably part of our ancestral, we had to do something to, make the animal last for more than a day. But I will say that I think we lose something in the nutritional value of cured meats. Like that fresh meat is coming with maybe more minerals or more, are we degrading some of the vitamin and some of the pieces? But as far as, do processed meats cause cancer? There's actually no data to support that. There's one statement in the WHO that they blame both red meat and processed meat, but actually in the red meat section, they did not come up with any data that actually supported that claim. So it was very weak. And again, most of it was all observational, right? We just talked about the classic meat eater, which is our pizza and hamburger eater, not our steak and broccoli eater. And then there was in the processed meat, they really cherry picked what they looked at. And there is some data that, I guess if you give processed meats to a rat that you injected with cancer, it might grow, but will it cause that cancer to grow? And in the observational literature, no. And there was a rat study that was done where they fed the rats a bunch of different meats. And the bacon-fed rats actually had the best-looking colons. And in that study, or in that WHO paper, they said the only link that they could even possibly say was in colon cancer. And it wasn't in any other cancer, yet somehow it's been blanketed over every single cancer is caused by red meat and processed meat. And yet we don't really have the data to say even colon cancer is. And so I'm not opposed to it on occasion. Maybe you're at a Super Bowl party and there's a meat and cheese tray, and that's the only thing that's on plan there. Have some, but that wouldn't be the best source of nutrition. That wouldn't be, I don't want you, maybe going on the bacon diet, but I think that again, optimizing our nutrition, that's really what a true ketogenic diet is. It's not the keto products and the keto baked goods and the keto whatever. That's not a ketogenic diet in my book. Mine is eating real ancestral, anti-inflammatory, nutrient-dense, foods that are made to nourish us. We eat for nourishment. We eat for all of these essential macro and micronutrients that we need to live and to run our body.
Coming back to our insulin piece here, being our common thread throughout the conversation, wanting to keep that low, or at least lowish and steady, gets me thinking about the elephant in the room being insulin injections for type 2 diabetics. So we know in that case, this person is metabolically unhealthy. They're going to be often overweight. They're going to have blood sugar all over the place, insulin all over the place, trying to control that. They've, probably pushed through insulin resistance for a number of years and gotten to this state where they're now injecting insulin to try and band-aid the effect of what's really happening underneath. Is there any research showing that when somebody's injecting insulin, that leads to cancer or helps facilitate its growth?
Yes, actually there is. And I don't have those on the top of my head, but there is data showing that diabetics are much more likely to get cancer than non-diabetics, and that diabetics on insulin are more likely to get cancer than diabetics who are not on insulin. And there's a potential, and this is where we get into repurposed medicines and things, but a little bit on metformin maybe being slightly protective. But what does metformin do? Metformin blocks carbohydrate absorption in your gut, which tends to lead to lower glucose and insulin. So is it really the drug that's the benefit, or it's the process of lowering carbohydrates? So why, unfortunately, is conventional medicine so focused on glucose, right? Because their whole role in diabetes is how do we lower glucose? They don't ever look at insulin. They think insulin is the lifesaver, right? We're going to inject you with insulin so that we can lower your glucose. But it's insulin that's the problem. And they actually, I don't remember when it came out, but in the diabetes literature where they said a hemoglobin A1C of 7.0, which is diabetic, was the goal. They didn't want diabetics at 5.0s or 4.8s or even 5.6s, because what they found was that if you pushed that glucose control lower, you actually did worse. But why? It was because they use more and more insulin to do that. So again, we have to always come back to insulin. So I always say if there's an issue like, okay, where Why? What was the metabolism behind that piece? What was the issue? So if somebody's keeping their glucose or their hemoglobin A1C at 5.0 because they are eating low carb and they aren't getting hypoglycemic episodes with their insulin, and they're not on high doses of insulin, they're on very low doses or no insulin, because that's what a lot of these studies are now showing, getting people off of insulin by going on ketogenic diets. Let's get off medicine. Wouldn't that be a major boon to decreasing cancer risk if we could turn around a whole bunch of diabetics before they get a cancer? That would be huge.
So we've stressed a lot, again, this insulin piece and managing that in a healthy way. Outside of that, when it comes to certain foods to include or not include to fight cancer, or things that are terrible and we don't want to include them because they lead to cancer. But again, taking insulin for a moment, putting it to the side, we've already gone into the details there. Are there specific foods that you recommend including to fight cancer and then eliminating that are big cancer causers?
So I think the biggest one outside of the insulin model, although it can play into it too, are the seed oils, right? The processed oils. Those have been shown in animal models. You feed the animals omega-6 fats like soybean oil or corn oil, and they grow cancer. And if you feed them, coconut oil and palm oil and those saturated fats, they don't. So we know that I want patients to have good quality saturated fats in their diet, and I don't want them to have those processed seed oils in their diet. That's like a non-negotiation. But I will say that I actually advocate for fewer nuts and seeds because they are still high in linoleic acid. And I have done testing because I look under the hood, and I will look at omega-3, omega-6 balances, and many of my nut and seed eaters, and so many of them are over consuming walnuts in particular because they have such a great omega-3, omega-6 ratio. But lo and behold, most of us, or many of us, don't actually have a good gene that turns that ALA, that alpha linoleic acid of the plant omega-3 world, into usable EPA and DHA. So they're essentially getting a huge load of linoleic acid of omega-6 fats with no omega-3 to go along with it. So I usually say we shouldn't be doing the keto like almond flour, baked goods, and, almond butters. And I'm not saying you can never do them. I'm just saying they shouldn't be part of an everyday diet. I don't think that nuts and seeds are where we should be getting our protein and our fat. I think that those should be coming from our animal-based foods. And then, if you want to do a little bit now and again, fine. You need a little crunch or a salt or, whatever. Okay. And then I really, outside of that, I don't get too much into the weeds. There are some people who I do recommend a full carnivore diet for, because I can see autoimmune issues. I can see maybe oxalate related issues. So it's another reason nuts and seeds tend to be less or lower on my list, because of lectins and oxalates and phytic acids. And I feel like they're binding some of the minerals we actually want to get. I'm a little bit of the Sally Norton camp of, let's stay away from, because I developed my own issues. So I was following a ketogenic diet, but doing a lot of the almonds and spinach and, dark chocolate and blackberries and, whatever. And then I'm in, having issues. And so I do think that we can overdo things. And so I always try to go back to ancestral days. And, my neighbor was growing strawberries one year, and he came over with a little handful. They have some of my strawberries, and literally 10 strawberries were smaller than 10 raspberries. I'm like, this is what natural strawberries look like. Like whatever we're eating is not really food. So I always go, how much could have been shared? How much would have been gathered? How much would we have really invested our time and effort into getting some of these plant pieces? So I'm a little bit more carnivore based, but that doesn't mean that I don't have patients who choose to do more plant-based ketogenic diets. And we just always keep coming back to numbers. And so we do identify maybe the omega-6 issues. Maybe we are identifying some other inflammatory issues, but some people do just fine on those foods. But that's why I like to look at labs and I like to constantly check in, because we're going to make these changes. And then maybe you read something and you decided to add in some supplements or something. And then we recheck labs and I go, wow, something looks a little off. Like, what's different? Oh yeah, I decided to add this in because I read something about it or saw something about it. And I'm like, oh, I think that's maybe not actually helping you because now these numbers are looking a little off.
You touched on the carnivore diet. I want to stick there for a little bit. And I'm curious, if somebody were to come to you and they're, feeling desperate and they've been diagnosed with cancer and they want to go all in and they want to know the quote unquote best diet. Again, nuance that it's going to depend on the stage and type of cancer. But why not go carnivore? Is there any downsides? Because you mentioned some of the plant toxins, and when we go carnivore, we're going to basically, it's the ultimate elimination diet
Yes.
to fasting. So we're going to be eliminating any potential plant toxins. Arguably, there's things in the plants that could do some good when it comes to cancer. So what I'm throwing at you is, why not carnivore if somebody is willing to go that route? Would you say that's the ultimate?
Yes. And that with the caveat of some people that go carnivore also do high dairy. So dairy is not always optimal for everybody. There's many of people who, if I'm really struggling with insulin or something, I'm like, oh, let's cut out dairy. Let's see if that's your hiccup. So yes, I will support anybody if they say, I want to go all in carnivore. I also have so I have a number of diets that I will share with patients, and I often will give them all of my handouts and say, you kind of look through them, see what you think. But I kind of have like, here's the carnivore one. Here's the carnivore with kind of low inflammatory plants. Here are the ones you could eat raw. Here are the ones you should be cooking. Here's, kind of an in-between. And then I have kind of a standard ketogenic diet, which is normally how I start most folks. Because again, I have some people who find me because they want to do carnivore or they're already doing carnivore. I have others that are coming to me from vegan and vegetarian diets and they're not ready to do that kind of a jump. And they like, let's just focus on getting you good nutrition first. And then maybe we can work our way to that if we need to. But yeah, so I will say that I do think that's the best for some patients. But some patients aren't ready to go there or aren't ready. That's just it depends on where they're coming from, because that could be such a huge transition. Like I have, you can imagine the people that are doing, I'm doing my flax, hemp, chia seed pudding with my, berries and my, maybe they're doing yogurt or eggs, but it's such a 100% flip. Even people who are eating regular, decent standard American diets where they know that, okay, sugar and, maybe even grains are not where I should be and I'm doing more real food. But like the idea of you need to replace your fruits and vegetables with literally the fattiest cuts of meat and add fat, like that, it's a hard mental place to get to sometimes for folks.
I hear you. But what I'm hearing between the lines here is that if somebody goes that route, it's not like we're omitting certain phytochemicals that are beneficial, because you hear things like turmeric, the potency of that being anti-inflammatory, green tea. Again, a lot of these could be missed, but there is certain phytochemicals that people associate with fighting cancer. So they're not going to miss out. The carnivore is not going to miss out on any of those.
Well, so yes, some call them phytonutrients. I call them phytotoxins. Again, I don't know. I don't feel like that data is very robust. And I do reiterate that if somebody is going to eat a plant-based diet, you absolutely need the color of the rainbow, because each of those colors do contain different nutrients, and you're going to miss, some of the nutrients if you stick to only X or only Y. But the animal-based nutrition is so replete with nutrients, and we are animals. We need different types and balances of amino acids and fatty acids and micronutrients. We're not growing, stems and roots and leaves. We're growing, bones and meat and, muscle and such. So I think that we need to get away from, again, I feel like the phytonutrients or chemicals in plants, I think are coming right back to that pathway blocker, that let's somehow create an anti-inflammatory response, as opposed to let's just remove the inflammatories and let our body be in an anti-inflammatory state. So I just come at it from a different perspective than that plant-based world.
Okay. So you've hammered home you're not a big fan of taking specific supplements to fight cancer, but I want to come back to something you talked about earlier, using supplements to build the body up as a whole. You mentioned a couple there. I know vitamin D was one, but I want to come back there and make sure we cover the array. So for somebody, say we'll just use prevention, or if they have cancer, what are the general supplements that you like people to take just to maintain their well-being and wellness?
I still will look at their testing, because if they're not deficient in something and then I'm telling them to take a supplement, then I'm actually throwing them out of balance. So normally what is your vitamin D level? Okay, yes, let's supplement vitamin D. What is your omega-3, omega-6? Now, sometimes I'll use some surrogates for that. I'll look at other markers and inflammation markers, et cetera, to say, wow, you're really high in your inflammation markers, so we probably need more omega-3s. We need to push down on your omega-6s. We might need to remove some other plant toxins, but of course the worst plant toxins are always the sugars, the grains, the legumes, the seed oils. So, right, we get rid of that part and then we're getting there. I might need to have people push sodium. So many people are taught, like, never eat salts, don't put any salt on anything, and their sodium levels are running quite low. And so sometimes I need to have them push some certain electrolytes. We might talk about magnesium supplementation. That's a common one. I feel like, especially as we transition from maybe a high carbohydrate diet to a high fat diet, sometimes we need a little support as we're kind of optimizing different metabolic processes. So I would say my most common ones are D, fish oil, magnesium, maybe other electrolytes, and then occasionally methylation support.
Okay. I know we're coming up on time, but I want to end on this. For somebody out there, well, everybody out there hopefully wants to do what they can when it comes to cancer and prevent and fight. But the exercise piece is where I want to end on. So this is something people have control over. They can take on and add it as an adjunct to the diet, to the sleep, the stress management, different things we've talked about here. But obviously, like everything in the health and wellness space, there's a balance. You don't want to push it too hard and all of a sudden be a couch potato and then try and start training for marathons just because you heard exercise is good when it comes to cancer. So what is the ideal dose? I think you mentioned walking before, and then the ideal type of exercise.
So if we're coming from the metabolic piece, from the glucose and insulin signaling, what we know is that kind of what we would call chronic cardio or steady state cardio, just going for an easy jog every single day, doesn't actually do much from a glucose and insulin lowering perspective, but doing some of the variable heart rate training, so high intensity interval training, where maybe you do maybe a couple sprints, or maybe you're not a runner, you're protecting your joints, you're going to do it in a different way, but you can, do something where you're getting your heart rate up and then letting your heart rate come down and doing a few repeats. That actually has been shown to be much more beneficial from a metabolism standpoint. So I usually say walking after a meal is great. especially in diabetics or especially people who are incorporating any kind of carbohydrate in their diet, because the muscle movement will help pull glucose in without the need for insulin. So it's a little bit more of an optimizing that insulin piece, but then increasing that glycogen depletion with that high intensity stuff. Again, more room for glucose to go, improving insulin sensitivity. And the other is always resistance training. So if we can put stress both on our bones, right? If we're lifting heavy, we're putting more weight on our bones. So especially for our women who are postmenopausal, increasing risk of osteopenia as we get our thinning bones, weightlifting, putting weight improves or helps your bones maintain density or improve density. And then if we increase our muscle density, not only is muscle density and muscle volume, so lean mass, associated with lower cancer, it's associated with better outcomes in cancer. Why? Well, do we have more glycogen storage? So not only, and our muscles, then we burn more of that sugar as we need to. So again, we know that people who increase muscle mass improve metabolic health too. So from a metabolic perspective, I usually recommend 2 to 3 days of HIIT, 2 to 3 days of lifting, or a combination thereof. Some people do their lifting in a HIIT fashion. So I'm not really, and I say, in the studies, I think they compared 30 minutes of chronic cardio or steady state cardio to 12 minutes of HIIT. Like you can do it in like everybody can do a little bit of HIIT, and you don't have to be mobile. So some patients, right, they're not going to get up and do a bunch of jumping jacks and push-ups and burpees and whatever, but there's a lot that we can do in varying intensities, or levels of fitness where we still are focusing on those primary principles.
Last question for you. And I know throughout our conversation, we've subtly given the answer to this, but I'm curious if there's any nuance for somebody that comes to you wanting to prevent versus fight cancer. Any big differences on things they want to do or avoid?
Not really. I just think that depending on where you are in your health journey, if you're pretty healthy and you're pretty active and your numbers look great, there might be a little more flexibility. And I'm not going to say, oh, you can never eat, fruit, vegetables, nuts, seeds, I think that some people choose to do that. They love eating that way. They love to not, like I have some guys that are like, wait, you're telling me I never have to eat another vegetable in my life? I'm like, if you don't want to, okay. Like, I'm sold, I'm in. Whereas others are like, I love my summer salads. Well, okay, let's figure out where you are and what can you do and what can you do on a reasonable basis. But if you truly look at diet and lifestyle as true, winners and losers, we wouldn't go around saying, oh, well, and some people do, so I guess I won't make judgment here, but I'm not going to go like, oh, I really love to, have a couple cigarettes every day. Like, no, that I know that's harming my health. I really get no value from that. So am I willing to take that risk for that? Like, what's my trade-off? So when you follow a ketogenic diet for a long time, a donut does not taste good. Coffee creamer does taste like chemicals. I mean, things change their taste, and you eat things that you used to like or that you thought you could never live without. And now you eat them and you think, oh my God, I liked that? Like, that's terrible. And so I feel like the relationship changes with all those foods. So even if somebody was looking to prevent, where maybe they have a little more like, okay, eating a donut now and again isn't going to kill you, but does it end up taking you down that path, that slippery slope where today you're eating one a month and then next time you're eating one a weekend and then, that type of a thing. So I think that all we can do is provide where the ideal is, and you have to decide where you want to live within that, where you're going to allow, because I don't treat them as like, ooh, I'm going to treat myself today. That's not a treat. That's a cheat. That's a toxin. And I did have a patient who said, yeah, every time I go to the bar now, if I want to get an old fashioned, all I see is like the skull and crossbones on it. And I think Dr. Kesslering told me it's poison, one time. And now that's all I think about. And so she doesn't have them. But one of the reasons why I always say, look under the hood, you might feel great today, but maybe you don't look great under the hood. So if we can just kind of keep coming back and check in, maybe once a year, looking at a big panel and saying, yep, you're still A-okay. Everything's still kind of on the okay page. And then you can choose at some point, if things aren't looking that way, is it time to make a change? But sadly, in our world, sometimes it takes a really big diagnosis for somebody to want to finally put in place all those pieces.
For sure. Dr. K, really enjoyed the conversation. I think this is a good place to end it. I mentioned the course before. We're going to link it up in the show notes. We're going to link up your website, social media. I just want to thank you for coming on the show and sharing this knowledge. It's just so important, and it's going to help a lot of people. Thank you.
Thank you. Been great.
Now that you're done my conversation with Dr. K, you're going to want to stick around here and catch my chat with Dr. Seyfried. There's a lot more to learn about treating cancer as a metabolic disease. I'll see you over there.
The body will turn on the tumor and dissolve it and eat it together with the diet drug combination.